and I request Dr. Harish Mehta to kindly come and talk to us about, is there any proven role for cardiac support in shock patients? Dr. Harish Mehta from Mumbai.
Thank you, Dr. Kumar, for having me over. Thank you, Brian, Dr. Sitaram. Before this study came, I was probably a believer of IBP too. I've used IBP quite a bit, so let's see what we hear about it. So this trial basically addressed a randomized comparison of intra-aortic balloon counter pulsation versus optimal medical therapy. And the main important thing common amongst them was early revascularization in acute myocardial infarction, complicated by cardiogenic shock. We all know the history of IBP. It was introduced in 1968. We know it improves the diastolic coronary and systemic blood flow, does help in physiological myocardial and oxygen recovery after STMI. It is also used mainly by cardiologists to prevent catastrophic catheterization events in the laboratory. It has become more and more mature with lesser and lesser French sizes coming, and it's still the most common cardiac assistance in acute cardiology today. But does it affect mortality? Well, the earlier trials before the IBP shock 2 showed us that most of them showed that IBP may be marginally better than no IBP, especially in MI. These were trials with no reperfusion, trials with thrombolysis, trials with primary PCI, the shock registry. Most of them did tell us that IBP was definitely helping preventing problems and to some extent reducing mortality. Based on this, you see that the IBP use kept increasing and went up to as high as 86% in the shock trial and 51% in the shock registry. But the moot question is, in patients with acute MI, complicated by cardiogenic shock, does an intra-aortic balloon pump really reduce mortality? These are the timelines. We need not go into that, how they designed this trial. The important thing to know is that comparisons, they took minimum 600 patients to compensate losses in follow-up and putative center effect. And the primary study endpoint was a 30-day all-cause mortality. The secondary endpoints which were included were hemodynamic parameters, serum lactates, serum CRP, serum creatinine level, creatinine clearance, and SAPS, which is the physiological score, and of course time till hemodynamic stabilization, catecholamine use, whether LVAD was used, requirement for renal replacement therapy, length of ICU stay, mechanical ventilation, and mortality after 6 to 12 months. They initially took 790 patients and finally randomized 600 due to various reasons. We need not go into that. And allocation was 301 randomized to IBP, 299 randomized to control. The important thing to note is 30 crossovers to IBP in the control arm, that is 10%, and 25 of them were protocol violations. And the other, there was 13 did not receive IBP because 10 died before IBP insertion. Revascularization strategy was intended early revascularization in both, and they matched all the way, and the follow-up was 30 days, and both lost 1 to follow-up due to withdrawing consent. Patient characters were matched. There was not much difference. The difference to note was the LVAD use was more in the control arm than the IBP arm, and there was a significant more mechanical ventilation, more catecholamine use in both the arms. And the acute physiology score, which is a factor of various scores, was better in day 2 and day 3, but did not continue after day 4. Renal function did not change in both the arms up to day 4. Serum lactate also did not differ whether it was an IBP or whether it was no IBP. Inflammatory reaction, CRP, did not change. And the most important, the primary endpoint, the 30-day mortality was almost the same. It was statistically not significant. So people, whether they received IBP or did not receive IBP, were doing equally well or either equally badly. And the 30-day mortality, there's always a comment that we did not know which one. So the subgroup analysis, which was pre-decided, did not show any benefit in either ways. What it showed, whether the MI was anterior or non-anterior, IBP or no IBP did not change outcomes. Previous infarction or no previous infarction did not show any difference. Even the blood pressure, there's a common criticism that maybe the IBP was not used in pressures, people with higher blood pressures. They found that blood pressure less than 80 versus more than 80, IBP versus no IBP made no difference. The bottom line came that in patients with acute MI, complicated by cardiogenic shock, there was no difference in 30-day mortality with IBP placement. Coming to safety issues, that's always been an issue when you use IBP, that there are more vascular complications, more strokes, more bleeding. Actually, none of this was seen. So IBP seemed to be safe. Even sepsis was equal in both the arms. And if you see all the randomized trials in cardiogenic shock with without IBP, the most important thing that stood out is that earlier revascularization is most important in all these trials. The earlier you revascularize, the better it is. All the others, whether you use the catecholamines, whether you use glycoprotein 2B3 inhibitors, did not change mortality as much as early revascularization did. So the main outcome that came was that early revascularization was the key in cardiogenic shock. So summarizing this, IBP support in cardiogenic shock is safe, we all know that, without significant inherent complications. It, however, did not reduce 30-day mortality in this large randomized multicentral trial. Primary study endpoints are supported by lack of benefit in the secondary endpoints. There was a great editorial comment that came after this. The results of IBP shock really tell us that the understanding of the management of acute and chronic heart failure, including those regarding the routine use of pulmonary artery catheters and the role of revascularization in ischemic cardiomyopathy. Based on the results from the IBP shock trial, the new 2012 ESC STEMI guidelines downgraded the use of IBP in STEMI patients from 1C to 2B. What we have learned from IBP shock is that approximately 60% of the patients will survive if we treat them according to guidelines. That means early revascularization in all and dedicated intensive care. Another positive effect of the trial may be a rethinking of when to provide left ventricular support. This statement came because if you remember the control arm, people used more LVAD than the IBP arm because they thought reflexively that in case they are not using IBP, if they use more of LVAD, patients will do better. But that's not really true. We need to revisit the LVAD. We need to have a proper randomized trial comparing IBP with LVAD to see that you may be causing more harm by putting an LVAD where it is not required. The criticism about the study that came was that LVAD was not controlled. So nobody knew what was controlled. And timing of IBP insertion was not pre-PCI as per protocol. And 80% of the IBP insertion occurred post-PCI. Lower mortality rates compared to the other randomized trials suggest that mild or moderately severe shock cases were included generally. There was a smaller sample size, 10% crossover rate from control group to IBP. Long-term results are yet to follow. And there was a high use of catecholamines and relatively low rate of systolic hypotension. But I would say what we learned from this trial is that despite all available devices and pharmaceuticals we have as of today, the mortality rate in cardiogenic shock is still above 40%. And our aim should be to continue to search for newer drugs, devices and techniques to reduce this mortality to acceptable levels. Over to you, Brian.
Thank you. Thank you, Harish.
Thank you, Dr. Mehta.